It's the news we dreaded, and the news is here. My name is Barkha Dutt, and you're with the Mojo Story, and we're here to look at the new COVID variant of concern as named by the World Health Organization. Let's take you through what we know so far and what it might mean for India. The variant has been designated with a name, Omicron. Initially, it was being referred to as the new variant, but now this is its official new name. Opinion is divided globally on what this might mean and how the world should respond. Large parts of the Western world have already responded with travel bans and restrictions to much of Southern Africa, where South Africa was among the first countries to transparently share with the world what its research had shown. Its strains have also been found in Hong Kong and Israel. South Africa has in fact objected to the travel ban, and many people believe that these are yesteryear responses to a problem that we simply have to learn to live with. The Prime Minister is chairing a COVID meeting amid new concerns. There's also a fresh new debate in India over the real-world efficacy of Covaxin, one of the two major vaccines that are being administered at home. Let's introduce our panel of experts today to talk about what we know, what we don't know, and how we should not respond. So, Sudhir Krishna is on the program with us. He's a professor with the IIT based out of Goa. We're also joined today from the United Kingdom, from the University Hospital in Birmingham by Dr. Wasim Hanif. Welcome to the program, Dr. Hanif. Dr. N.K. Ganguly, who has been the head of the Indian Council for Medical Research, is with us. And Dr. Rajesh Parikh, who's, of course, a doctor at the Jaslok Hospital, but also the author of several studies and a very important book on COVID, is with us as well. Dr. Hanif, I'm going to take this chance to start by asking you to place this in a global context. I've seen the statements that have come out of the UK government. We've seen Professor Chris Whitty saying that we are better equipped to deal with this new variant than we were, for example, with the Delta variant. We cannot be hitting the panic buttons all over again. London, where I am, at this moment is fully open. There could be, of course, the red listing, as has happened, of several countries from Southern Africa, but many are saying this is an archaic response. Can you take us through what we know globally thus far?
Thank you. Thank you very much, Barkha. I think one of the things we have to really understand this is in the context of the situation that we are in now. The last time we had a peak, which was the start of the Delta variant, which hit India, UK, and the other countries, there were a lot of factors that were responsible for the high rates of infections, the mortality and the morbidity that we saw. The vaccination rates at that point in the UK were very low. Most of the people, or a few of the people, had the first jab. They did not have the second jab. The equipment that we had in terms of the treatments for COVID were very limited, except dexamethasone, which was the only proven treatment. There was nothing else out there. A lot of things were being tried, but they were not very effective. And also the response of the government and the society and the public health could have been better.
Of course.
But now we are in a situation where in the UK, about nearly hitting 90% of the people have had two jabs. We have got another 15 or 17 million people who have had a booster jab. And what is probably missing in this, and this needs to be emphasized, is the number of people who have already had COVID. The seropositivity is hitting about 92%, and the data from India again is suggesting in cities at least it's hitting around 90%. So people have already got a lot of have been exposed to COVID. When in the first and the second wave, COVID was a new virus that was hitting the humans having been evolved from other animal sources. So at that time, the response that was expected, and this has happened if you go back into the history and look at all the pandemics, the first and the second wave hit you the hardest.
And I
In the
want to
third
jump in
wave,
here. I want to jump in here because the United Kingdom of many countries is a grand success story of vaccinations. As you mentioned, even the booster drive has acquired great momentum. At the University Hospital in Birmingham, have you seen enough proof that vaccines are doing what they're meant to, which is that they won't always stop you from having the infection, but they will stop you from getting into the ICU, or they will vastly reduce those numbers. That's
okay,
the accurate thing to say.
I think that is probably the best marker for us to see how effective you're working. So just to give you a perspective, University Hospital Birmingham is one of the largest trusts in the UK. We had the largest number of COVID patients that have gone through. So at the height of the first peak, we had about 200 patients in the ITU. Now our ITUs are almost about two or three, not more than 15 or 20 patients in the ITU. If you look at the numbers, and this is the data that's come up from the IKNR, which is the ITU audit data, which is very effective. So the last time when UK had 45,000 patients, the number of patients when we're having 45,000 infections a day, the number of patients in ITU was much higher. And now it is about 1/6 lower, which
Yeah.
effectively means that the vaccinations are working. That is the reason why we're not seeing those many ITU admissions, and the cohort of patients who are being admitted to the ITU has changed.
Yeah.
Previously, it was elderly patients. Now, the most patients in the ITU, unfortunately, are pregnant women who are unvaccinated.
And I think the emphasis, of course, it's sad to hear about the pregnant women. We saw that happen in our second wave in India as well. But what you emphasize, most people coming into the ICUs are unvaccinated. Dr. Rajesh Parikh, this is now being called increasingly a pandemic of the unvaccinated. And as we look at a new variant that has emerged and is being studied, Pfizer is promising readapted vaccines if needed within 100 days. We have actually now a sort of array of potential therapeutic drugs that are being looked at, from monoclonal antibiotic cocktails to other therapeutic, which is preventive, to therapeutic drugs as well that are being looked at. My question is this: instead of travel bans, lockdowns, chest beating, sealing borders, isn't it time to mandate vaccines? South Africa has 24% only of its population vaccinated.
Oh, absolutely, Barkha. I mean, opinion is divided on the mandate, and there are persuasive arguments on both sides. I can only state my position, and that is that yes, some kind of mandate is called for. I'm personally not in favor of any coercive measures or ones that infringe on people's basic rights, because
But
we
it's
have
not
to
about their
protect that.
basic rights. They are
Yes.
impacting my right as an individual to travel freely, to conduct economic activity. If states panic and start imposing restrictions on economic activity, the stock markets are crashing globally. We're already back to 2020, 2021 language with travel ban and travel restrictions, discouraging countries from being transparent. How can vaccine mandate still be under debate where vaccines are available?
So I can tell you where they can be under debate and why I believe they should be under debate. And you, as an advocate of free speech and somebody who's been practicing it fearlessly over time, would also, I'm sure, appreciate that one can go overboard. So if you'll allow me to explain where I feel we should draw the line. I was saying that it shouldn't be coercive, it shouldn't infringe on basic rights. But let me tell you what's happening. Now, about 3 days ago, any government official in the United States could not show up to work unless he or she had both vaccines. I was in New York 2 weeks ago, and I was in a conversation with a reasonably senior government official who strangely happened to be an anti-vaxxer. And he said to me, and I'm quoting him actually, he says, I've had to take this stupid vaccine because otherwise I could lose my job. So to that extent, where you have some mandates where people are forced to get vaccinated for other reasons, that's fine. But if we are going to curb free speech, if we are going to knock on people's doors and vaccinate them forcibly, those are measures that can go wrong. I mean, sometimes the way to hell is paved with the best intents. We know what happened during the sterilization campaign during the emergency. The overall intent was good, but it spun out of control. So yes, I am for vaccine mandates, but I believe that you will be with me when I say that we're equally for free speech. I mean, there's talk of not allowing people to get rations, depriving people of transportation, a lot of things. And on
Well,
the other hand,
I would respond by saying that if the state is unable to provide its citizens vaccines, it has no business imposing mandates. But in our country, we have crores of people who have refused to show up for their second dose, and it is unfair that in their willful stubbornness in not taking the second jab, the entire country should suffer. So my argument would be that the new variant tells us, Rajesh, that we need to link vaccines to enough economic activity, much like the Aadhaar card, that you simply need it to get on with your life.
With you entirely. In fact, I've gone on record as describing the anti-vaxxers as bioterrorists. That whereas terrorists in the conventional sense are spraying bullets at us, the bioterrorists are spraying viruses on society. And it has been observed in studies across the world that there is an enormous intersection between people who refuse to get vaccinated, people who refuse to wear masks, people who do not maintain social distance, and people who are in fact COVID deniers. So yes, these are dangerous people, but we need to find out better ways of getting them to get vaccinated rather than indulging in a campaign which could spin out of control, particularly in countries which are not committed to democratic values.
Okay, let's come back to the new variant, Dr. Ganguly and to Sudhir Krishna. Dr. Ganguly, I'll start with you. Last week on this very program, we were discussing the decision by the Indian Council for Medical Research to rule out the need for booster doses at this point. The argument was that not enough of our people had gone through 2 shots. That was the first argument. And the second argument was that there wasn't enough science. In fact, some scientists have suggested that the Covishield/AstraZeneca vaccine, which most of the United Kingdom has also got as its first 2 shots, took a longer time for the resistance to wane compared to the mRNA vaccines. Now we have a new variant. Should we be reconsidering our position on booster doses, especially given the fact that so many vaccines are going waste, about to reach their expiry date in private hospitals, Dr. Ganguly?
Actually, if you really look at the one argument was that the short-term immunity is only those countries where they have got messenger RNA as both the doses, but that's not true. The AstraZeneca vaccine was given in Britain quite extensively, and this also wanes. So around 5 to 6 months it wanes, about 9 months it definitely wanes. So there are huge number. We don't know much about Covaxin, but now the Johnson data also, some analysis is there. They have also said that you need to get a second dose. So with all of this background, those who are vulnerable, they should get a second dose. Now about this particular strain which has come up in South Africa, it has got 30 mutations in the spike protein, and it is much more transmissible, and it is causing serious infections. It also has a problem that it doesn't respond to vaccine, even lesser than the Delta variant. So that is in vitro test which they have done. So with all this, and WHO within few days declared it as a strain of concern. So we should at least, I will like to get a booster dose. I'm vulnerable. I'm 80-year-old, and I have my vaccination date was more than about 7 months. So we need to, if we have enough vaccine, if we don't have vaccine, then it's a different case. The second point which I will like to make, that why people are not coming for the second vaccine dose is because we are not communicating well. People, we are thinking in India, thinking is going on that it is over. 90% of people have got as Dr. Hanif said, that 90% of people have got exposed, so they might have herd immunity, and we are not seeing much COVID cases in India. So we need not worry. The life is going on as usual. But let me tell you, COVID has not gone. We will have, if we go on like this, we will have a pie where there's a large number of people who are unvaccinated, 19.5% people who have not taken second dose. Many people were not immunized, like children are not immunized. Pregnant women are not wholly immunized. So all of these people make a very huge amount of
I think you make a very important point that the kind of complacency that we saw before the second wave, which caused the second wave in India, could be coming up again. But I do want to add one point as I go to Sudhir Krishna. I do believe that countries all over the world have underestimated what I actually describe as a psychological threshold. I believe that the world has crossed, or much of the world has crossed, a psychological threshold. Those of us who've been lucky enough to be able to travel outside India are able to see this in large parts of the world. It would be almost impossible to send people back into their homes again. I think lockdowns are passé, travel bans are passé. Maybe what we should be focusing on is exactly this: booster doses, mandatory vaccines, and those kind of measures. Sudhir, is there now in India, should the first response be that instead of those vaccines reaching those expiry levels in private hospitals, they should be dispersed quickly for the vulnerable sections of the population, the elderly and the frontline workers? Could that be at least a practical first response in India, though it has been ruled out just days ago, but that was before we knew about this new variant?
Thanks for having me on the show, Barkha. I actually want to focus on two aspects of the Omicron, and I'll do it whenever you feel it's appropriate. One is the structure of INSACOG, which is supposed to do the sequencing for Omicron, and that's part of this complacency issue. From what I gather,
so if you can explain to our audience, you are talking, of course, about the group that is responsible for studying the genome sequencing of the mutations, right?
Yes, the sense. So it's a government-led initiative, and I'm glad Dr. Ganguly is on this show because he's got a lot of administrative experience. The extreme criticism of INSACOG is that they're only publication-oriented and they sequence in retrospect. But what we really now need right now is active surveillance. And because they are so unfriendly to the private sector, who actually does sequencing very quickly, is very competent, is very quick at many things, but the setup is very micromanaged. We have a poor system in place. So I'd like Dr. Ganguly and other people in the system to respond to that. The second point is that I think I am a spokesperson for an Indian and African consortium on dengue vaccines. And I think we have some insights on how we can rebuild the vaccines, which is a sort of hybrid of both nucleic acid, single proteins, and the subunit or the large inactivated.
And could I ask you if the talk of rebuilding the vaccines applies only to the mRNA vaccines, or it applies to the Covishield and Covaxin as well? Because the one thing that was said about the mRNA is that they're faster to adapt.
So I'm actually referring to the DNA vaccines, but yeah, the same principle holds for the mRNA vaccines. So the mRNA and DNA vaccines which exist right now are single protein vaccines. They're spike protein vaccines. The inactivated vaccines have the entire lot of them, and they have their strengths because there are many proteins out there. They're also now subunit vaccines. The DNA work, which I was talking about, and I'm really a spokesperson for a very large Indian and African consortium of very talented people, have done three things. They've made a DNA vaccine which has multiple subunits. So it's got an internal protein, which is the NS1 protein. I just want to add a point to what Dr. Ganguly said. There's not just mutations in the spike proteins, they're actually mutations. They're scattered all across the genome of this new variant that we're talking about. So this approach that we're talking about is actually expressing multiple subunits. In the case of dengue, what we've done is internal proteins and small little bits of the various serotypes. It's also based upon very large-scale DNA sequencing of the dengue. So I think we can help with insight. The paper is up on medRxiv and it's in the final stages of peer review. But I think it's an approach which helps to bridge many of the approaches right now. We can talk about it whenever you want to.
Okay, we'll get into that in a moment from now. We'll get into that in a moment from now. I want to just go to Dr. Hanif, Wasim Hanif, and ask you this: in United Kingdom, the decision has been for the booster dose to be an mRNA and not an AstraZeneca vaccine. Why is that? Can we unmute him, please?
Yeah. Thanks, Barkha. I think it is purely based on the evidence that exists. So the JCVI, or Joint Committee on Vaccination and Immunization, At that point of time, the data that was published when the booster program started was with mostly with Pfizer, and there was some data with Moderna. There was no data with AstraZeneca, and that is the only reason that Pfizer came in as the booster vaccine. But I'm sure as the more evidence comes in for booster with other vaccines, that is going to change.
But I'm a bit confused because we're all saying booster shots in the light of this new variant, but we don't yet know, or do we, how the vaccines are responding to this new variant? Do we have any science on this, Dr. Hanif?
I think it is too early for the science. And I think this is where, you see, we need to be cautious and watchful, but not alarmed. And that is something that is very, very important. Now, when it comes to vaccine escape, what do we really mean by vaccine escape? So I'm a clinician, so I'm seeing patients on the ground. Now, what to me a vaccine escape is that if more of my patients get seriously ill who had previous COVID or have been vaccinated, who end up on ITU or who sadly pass away. Now, if the vaccine escape just means that the patient's getting mild COVID or a bit of flu, that is clinically acceptable.
Exactly. I
Immunologically,
find the
or for
focus
the
on vaccine
epidemiology,
escape misleading and causing
absolutely.
enormous fear in the
Yeah,
general public.
yeah, and I think this is very, very important for us to understand that what do you mean by vaccine escape? Now, if you look at my epidemiology friends, they would say anytime you get a asymptomatic or a PCR infection, that is vaccine escape. But from a clinical point of view, that does not affect patients. That should not affect our economic life or a social life. And you were talking about the psychological pressures that has created. But one of the very important points, and this is something that is missed in a lot of cases, is what we call the unseen burden of COVID pandemic. And this is patients with chronic disease, be it patients with cancers, patients with diabetes, patients with heart disease, who are not able to access the regular treatment. And the excess mortality we are seeing in these patients.
Yeah.
So we have to adapt to live with the pandemic around us. And I can do understand the panic that has set in the moment there is a new variant, but we have to be watchful, but not alarmed.
I have to say that I literally endorse every word you have said. Personally, having seen patients suffering from cancer and tuberculosis in India, literally dying on the streets outside hospitals that couldn't cope with those illnesses because they were so COVID focused. And I think that the operative part of what you've said is we are now at a stage where we need to learn to live with this pandemic. Dr. Parikh, I will take that to you. You know that one of my bugbears, and thankfully countries, our part of the world has outgrown lockdowns, but many parts of Europe have not. And you've seen parts of Austria, for example, go into lockdown. You've seen Germany announce new restrictions. But I think Dr. Hanif is absolutely right. This theoretical focus on vaccine escape. Why are we focusing so much on contracting the infection? Our dashboard should only be talking, in my opinion, about hospitalization, serious hospitalizations and deaths. You're on mute.
In your endorsement. Yeah. And I'm going to begin with two sins that we spoke of when we first wrote the coronavirus book 2 years ago at the start of the pandemic. The first is a cardinal intellectual sin, and we're seeing the repercussions of that causing the confusion that you alluded to. And the second is the original antigenic sin, which is actually a biological term. Now, coming to the first, it has been said that oversimplification is the cardinal intellectual sin. And what we are seeing in the discourse, even in medical circles, tends to be the vaccine, the human, the virus. So does this vaccine work very well against the virus? What is the efficacy? But it's far more complex than that. So let's begin with the human factor first. Each of us is constructed differently. Given the same vaccine, our immune response is going to be different, even in twins, unless they're absolutely identical. So there's the human genetic factor, which can be factored out, by the way, with AI algorithms. And second, the virus, as we are learning now, there are various mutations, and now 14 mutations, the last one that you started the program with. And each mutation, based on what happens with the spike protein and other structures, is going to behave differently. And then there is the interaction, the antibodies that are produced by the human. And all of these are going to react in complex ways. For example, an individual, let's say in Delhi, who's getting a particular viral mutation, who's facing a viral mutation, might respond differently to a vaccine, also based on the viral load that he's being exposed to. I mean, to state the obvious, vaccines are not fighting the virus. Our antibodies are. Vaccines are stimulating these antibodies. So our antibody response will vary based on the viral load, based on the mutant. And I see now that these algorithms are going to be complex enough for AI to step in to factor out that in which geographical area, with which viral mutation, will which vaccine work. And I believe that's what Sudhir was alluding to when he spoke of the need for surveillance. So that's one part of it. And the second is the original antigenic sin, which is a very simple concept that every time you're infected, the body is going to behave differently, for better or for worse. So it's not a sin in that sense. It's a biological response. And as people get exposed to different variants of the virus, which for practical purposes are actually almost like different viruses, and their bodies are going to respond differently. So it's a gross oversimplification to say that vaccine A has an efficacy of so much. Well, it did initially when we were early in the game, but this is going to get far more complex.
So that takes me, in fact, to the debate that we're witnessing in India. We have an added debate, and that debate is around Covaxin. A sort of report published in the Lancet based on an All India Medical Institute real-world, real-time study as the surge of the second wave was happening, this needs to be emphasized, found that there was a gap between what Covaxin had reported in its efficacy report and what these doctors, who were the subjects of their own study, witnessed with health workers during the surge. They have caveated the fact that the study took place during the second surge. So that needs to be underlined because vaccines are not a response while a surge is happening. Dr. Ganguly, should Indians be concerned, new variant on the one hand, and a raging unresolved debate around Covaxin now on the other? How do you see this debate, Dr. Ganguly?
Actually, the both studies designs are slightly different. Like the first Covaxin, which was study of phase 3, which was published in Lancet, gave 78.6% protection. In that, the severe cases and hospitalization cases and death were also counted. In the second Covaxin study, which was incidentally done by the All India Institute of Medical Sciences, and the Indian Institute of Medical Sciences actually carried out the main Covaxin study. They took record of, this was a live situation, they took record of all the doctors and the healthcare workers who had received the vaccination, how many of that got infected by RT-PCR. And they found that 50% of those got infected through RT-PCR. This is a quantitative thing also, so they must have got significantly infected, but they haven't calculated the severity at the given moment, nor they have calculated death. So 50% got infection after vaccination. So this is the story at this given moment. Normally vaccinated may get infected, but those who have got double vaccination, they do not die.
So when you see this study, do you feel that it's an apples to oranges, that the report that claimed nearly 78% efficacy against symptomatic COVID was measuring different parameters at a different time than this All India Medical Institute? Like, how worried do we need to be? I mean, I think the simple layperson's question, some of us have now immersed so deeply in COVID, we forget that, Dr. Ganguly, that the layperson reads Covaxin 50% efficacy and thinks they've got the wrong vaccine. So what would you say to them?
Yeah, actually, that's why I try to explain this to people, that don't get panicky. However, what we don't know in Covaxin, that how long the immune responses last. But with whatever we now know, because many of the hospitals have got their data analyzed, like All India Institute. The data in which I have laid hand on, I am associated with 3 hospitals in Delhi. What we have found, that really immune responses don't last long. But I will confess that neutralization antibodies were not done by those. Only ELISA antibodies were done. So in these situations, and those who are undergoing transplantation, they are going renal dialysis, those have a
Right.
serious problem, they should get a booster. I think, as you have said, Barkha, rightly, we have large amount of expiry date vaccines which are available. We should at least save lives of those who are vulnerable.
I mean, I think it's just criminal for any part of the world to be allowing vaccines to move into expiry levels. It is criminal. It is morally criminal. It is reprehensible. And I would almost rather have an absence of vaccine equity at home than have the vaccine go waste. If those are the two stark bad choices. Sudhir, you've been wanting to make a couple of points. Let's bring you in on the co-vaccine debate and then move into Omicron and what the response should be. Go ahead.
Actually, the Covaxin aspects has been covered by Dr. Ganguly and Rajesh in different ways. Any glance at the literature, I mean, if you scan the internet, a lot of the vaccines showed very variable responses when they were in, healthcare situations. The early reports of the mRNA vaccines were not with Delta. When Delta came along, they dropped by about 30% and so on. So that's the case with the other vaccines. There's a lot of literature with Covaxin and Covishield. They've both done well. I'm very concerned about the adenovirus in Russia. I don't know why that's happening and why Russia is doing so badly, but I just don't have enough information to understand that. In terms of the vaccines that I was talking about, I agree with you that we must finish what we have in hand and we must continue sensibly. I was just saying that if, just like Pfizer this morning, I think announced that they're not sure that their current spike protein will work. So what I'm saying is if vaccine rebuilding is going to happen, we can certainly contribute significantly to groups who are interested in working with us and working with our colleagues in terms of redesigning the vaccines to express multiple subunits. We have the bioinformatics capacity to see how they can be modeled across multiple mutations. We have the capacity to see whether they can work across genotypes. The DNA vaccines work very well. Shweta and other colleagues in my lab are also working on an mRNA vaccine on the same lines, so we can compare vaccines. So yeah, we can function as a resource now, which is pretty cutting edge.
Okay, I need to sort of move into last comments now. I'll start with you, Dr. Wasim Hanif. I think you made the very important point of not hitting the panic button. Now, Pfizer's comment, for example, can be read in two ways. One, as Sudhir did, that actually maybe the vaccine doesn't work against the spike protein of this new vaccine. They also said in 100 days they can adapt the mRNA to a new vaccine. Also, I think as you emphasized, we need to define very clearly what we mean by a vaccine not working. What does it mean? Does it mean it can't protect you from death? Does it mean it can't protect you from ICU? Or does it simply mean it can't protect you as efficiently as before from getting the infection? Even I, having been obsessed with COVID for 2 years, don't actually know what it means to say the vaccine doesn't work. What does it mean?
Okay, let us just take out from the COVID debate and to understand what do you mean by an effective vaccine. Mm-hmm. So we have got the flu vaccine, which doesn't work more than 60%. And the only reason you have a flu vaccine is to stop you from getting seriously unwell and dying. And in the UK, about nearly between 20 to 50,000 people died from flu. Now, we will probably end up with COVID in a similar situation, probably in 2 years' time or 3 years' time. What has happened is a lot of science of clinical medicine has been practiced on the media in front of us. Seeing those scenes, be it in Delhi or in Austria or in the UK, of the patients dying, has created this panic that any time when we talk about vaccine not working, we'll start talking about seropositivity or mild or asymptomatic infections. The two studies, the Covaxin studies, actually reflect that. If you're going to go and do a study in doctors or healthcare workers who are working during a surge when there is a huge amount of viral load, you are going to get mild infection. Doesn't matter whether you have 2 doses or 3 doses.
Yeah.
That is the time for you to start using the mask. Still, I'm triple jabbed. When I go and see my COVID patients, I make sure I'm wearing the full PPE. It's not because I'm kind of testing it. It is just common sense.
Yeah.
So coming back to your question, what does it really matter? What really matters is patients getting seriously ill, getting into ITU, and sadly dying. If we can keep those numbers down, as the data still is showing from the UK, then I think we shouldn't be alarmed. We should.
I agree. I agree. And thank you for putting that into such clear context with the example of the flu vaccine. Dr. Ganguly, before I give Rajesh Parikh the last word, if you'd like to sort of have any word of advice for the Indian response at this point.
Yeah, I agree with Dr. Hanif that we should take all the care COVID the reason practices at every place which is risky. The second point I will like to make is that we need to inform people correctly. We should not have misleading messages for the people. And finally, we need to work on, India is very good in science. We need to work the newer vaccine. All these vaccines were made in a hurry, repurposed with the old platforms. There's a lot of scope to make a better vaccine with multiple antigen targets. As Sudhir was saying, we should do that, and we should sequence more. Sir, we should do more surveillance. The UK does millions. We do 20,000, 30,000. That's not enough. We should do it. We should do it on real time. We should do it with public health guides, and appropriate public health messages analysis should be done with that. Thank you.
Absolutely. Dr. Parikh, I'll give you the last word. What is that space between not hitting the panic button and not using responses that clearly failed? We now know, if for India, we know a national lockdown can never work again, for example. We also know that travel bans, and we're seeing that debate online everywhere today, are going to discourage countries from being as transparent as South Africa has actually been. So what is the appropriate response, you believe, at this point?
I think the WHO for once has got it right. They've talked of a variant of concern. We do need to watch not just this variant, but there are going to be other variants undoubtedly which will emerge, which have to be watched. But there has going to be now a shift in the way we look at these things. You know, you alluded to comparing apples and oranges, and that's the way we looked at it. But now it's going to be a question of comparing apples with other apples. For instance, you know, there are 7,500 varieties of apples. And while all of them are not relevant, somebody who likes apples, as I do, would clearly know the difference between, say, a Granny Smith and a golden apple. And, you know, it has been said, Barkha, that the Inuit Eskimos have just one word for any object that flies, okay? Whether it's a bird or a plane or anything that flies, they have a very limited vocabulary. But when it comes to ice, they have 35 different words for ice, depending on the consistency, texture, various things. And so I think we're going to see a shift where we're just not going to talk of vaccines. We're just not going to talk of, oh, Covaxin is good and Covishield not so good. It's going to get far more
much
complex.
more specific.
More specific. And we are going to now again move into an area which has now taken a backseat for some time, which was personalized medicine. It took off 4 or 5 years ago. It's now quiet, but I think it's going to re-emerge where we are going to look at personalized vaccines. We should be able to tell based on somebody's genetic structure, based on the viral mutation, based on the antibody response, perhaps as a test, as to which particular vaccine is most likely to work for a particular individual. But that doesn't override what you've said. We have to look at disease. We have to look at death. Those are on the dashboard, and that's very, very important.
I was just going to say that sounds fascinating, but we're still some distance from that when we can't, when 12 crore Indians do not turn up for their second jab, which is available to them. And therefore, our emphasis must remain on vaccination. And I will still sort of lean in favor of mandating vaccines and linking them to as many activities as is possible where vaccines are in supply, because citizens choosing not to get the vaccines where the vaccine is available are punishing their fellow citizens. And that is where many of our freedoms end. We'll have to leave it there. Dr. Hanif, Dr. Parikh, Dr. Ganguly, Professor Sudhir, Krishna, thank you. We will track this new variant very closely, but without panicking and keeping context always in mind. And remember, when you hear the term vaccine escape, ask the next question. Okay, maybe you can get infected, but is it still protecting you from getting seriously ill? If it is, it's doing its job. Go take that jab. Thank you for watching. See you soon. Bye-bye. It's great to see you here. Thank you for watching our work. If you haven't subscribed yet, don't forget to click the bell icon and subscribe to Mojo Story and support independent, robust journalism.